Hello, everybody. My name is Srisharan Veeturi, and I'm a postdoctoral associate in the Department of Neurosurgery at the University at Buffalo. And I'm going to talk a little bit about the research we are doing in our lab, particularly um, in the aspect of intracranial atherosclerotic disease, or ICAD, as it's known. Now, ICAD is a systemic disease that occurs due to fatty buildup of plaques in the intracranial arteries, and these plaques can eventually grow and occlude the vessel, which can cause stroke in the patient. Now, these plaques are identified in medical imaging such as CTA or MRA or MRI, and multiple studies in the past have shown that culprit plaques, or the cause which, or the plaques that do cause the stroke, have actually distinct radiographic signatures than those which do not cause the stroke. However, it's still unclear as to how these plaques behave on a longitudinal data set, and can we use the imaging from the first time point to better understand how the plaque would behave on serial imaging. So that's what we try to do in this study. In this study, we tried to look at ICAD patients and look at the plaques in them and try to predict a priori if they will grow on serial imaging or not. Now, the reason why we do this is because to start with, once a plaque is recognized, the patient is put on statins, which are a class of cholesterol-lowering drugs, and that sometimes, in most cases, actually reduces the plaque burden and reopens the vessel. But in about 35% of the patients, this has no effect, and in such cases, we need to treat the patients using surgical intervention, basically placing a stent to reopen the vessel. But the stenting itself has certain risks associated with it and should only be saved for those cases which do not respond to statins. So there is a critical need to understand whether a plaque will grow or not. And in this specific study, we used high resolution vessel wall imaging through a 3 Tesla MRI to serially image ICAD patients across two different time points, which were approximately a year apart. The vessel wall imaging protocol included a time of flight MRA image, a proton density weighted MRI, and a contrast enhanced T1 MRI scan. And then once these scans were obtained, we registered all of these images onto each other, and we then manually segmented the individual plaques based on the radiology notes. Now, once we segmented the plaques, we have a region of interest or a collection of voxels, and we extracted radiomics features from the proton density image as well as the contrast enhanced image. And we then used these radiomic features to further develop our multivariate models. However, the process of manually segmenting these plaques has some variability in it, and thus we decided to perform an inter-user variability analysis. Excuse me. We identified 10 representative plaques and asked two different users to segment these plaques, and we used the difference between these plaques to um, basically to inform us if a plaque is regressing, stable, or it is progressing. And we also excluded plaques that were less than 5 millimeter cube, since they may have the variations in these in segmentations will have a non-negligible effect in that case. Furthermore, for data quality purposes, we also used only those radiomics features which were highly correlated between both the users. So we started off with 109 plaques from 38 patients, and we ultimately ended up using 78 plaques from 26 patients, out of which 39 were regressing, 18 were stable, and 21 progressing. This is a representative figure of two different segmentations by both the users. We observed a dice of 0.75 on approximately, and it turns out that the average difference in 10 cases between the volumes of the of the two users was approximately 7.87% volume difference. And the standard deviation was actually 7.87%. And twice of that would be 15.7%, which is the volume threshold we used to determine if a plaque was regressing, stable, or progressing. Basically, on the second time point of imaging, if the plaque reduces by more than 15.757%, we say it's a regressing plaque. If it's anywhere between -15 to +15, we say it's fairly stable. And if it's more than 15%, then we say it's a growing or a progressing plaque. We in total we extracted 99 radiomics features from which we found were significantly correlated between both the users. And furthermore, we performed ANOVA analysis and Kruskal-Wallis analysis if they were non-norm if the radiomics features were non-normally distributed. And we saw that about 26 radiomics features were significantly different in at least one of these cohorts. A representative figure is shown over here with a violin plot of one of these radiomics features shown on the right. We also then performed a univariate analysis between strictly progressing plaques and all other plaques. And we found that there were 49 radiomics features, which were significantly different between progressing plaques and the rest of the plaques. Out of these, a majority were from the proton density imaging, 28 to be precise, and 15 were from contrast enhanced MRI, and 6 were shape-based features. We then eliminated all the collinear features from these features, and used the subset of those features to build a logistic regression model. The model performed fairly well with an AUC of 0.77, and these are the odds ratios of all the radiomics features used to build the model. Finally, we have a representative figure of a regressing plaque in figure A and a progressing plaque on figure B. The regressing plaque we see here is an example of a basilar artery plaque, where on the second time point, the blue shade you see goes down. But in figure B, we see a progressing plaque where on serial imaging, we see the plaque volume increase. And so through this preliminary study, we showed that the progressing plaques do indeed have distinct radiomics features, which can help potentially identify progressing plaques a priori, um, to for, to help clinicians make informed decisions about their treatment planning with plaques. Thank you.